Good morning. I have a patient today. His name is Mr. Pawan Jain. He is from Indore and he has come to our department for a IV adenosine myocardial perfusion imaging to find out how much earlier perfusion scan the defects which was there, how much it is improving or how much it is increasing or how much, what is the status. He was on beta blockers and anti-lipidemic drugs, and beta blockers he has stopped from Monday onwards, and in this condition he came. So just to tell a little bit of history, he is a hypertensive, dyslipidemic, and he has a family history of ischemic heart disease. His father and brother, they are known case of ISD, and he is non-diabetic, he is not a smoker, that's all. So with this, he came to our department, and I will just ask Mr. Pawan Jain regarding his symptoms. पवन साहब, आइए बताइए आपको क्या क्या सिम्टम होता है, कि क्यों, कैसे शुरुआत हुआ आपका हार्ट की प्रॉब्लम, ये आप हमको बताइए।
एक्चुअली हम लोग अहमदाबाद गए थे, वहाँ मेरा बेटा डॉक्टर है, तो हम लोग स्विमिंग कर रहे थे। स्विमिंग करते करते उन्हें लगा कि आप अच्छा स्विमिंग नहीं कर रहे, मतलब सांस आपका फूल रहा है, बोले कि आपका जांच करवा दिया जाए। तो उन्होंने फिर जो है डॉक्टर को कंसल्ट करके और जांच करवाया मेरा हार्ट का एंजियोग्राफी।
नो, इससे पहले आपका ट्रेडमिल स्ट्रेसिंग हुआ था, तो उसमें कुछ पॉजिटिव आया, तो ट्रेडमिल स्ट्रेसिस पॉजिटिव आया तो फटाफट वो लोग कार्डियोलॉजी लोग सीधा करते हैं एंजियोग्राफी। दे डोंट डू आवर मायोकार्डियल परफ्यूजन इमेजिंग स्टडीज। सो आपने ट्रेडमिल स्ट्रेसिस पॉजिटिव आया, सम ब्लड में एसिडिटी चेंजेस आया, फिर आपको एंजियोग्राफी किया। हाँ, बताइए।
फिर एंजियोग्राफी में ब्लॉकेज आया और मुझे बोला कि भाई आपका सुबह ही बाईपास होगा, तो मैं घबरा गया एक्चुअली।
आपको बाईपास करना है?
हाँ, बाईपास करना है। तो
आप घबरे गए? यस।
मैंने कहा नहीं, ये मुझे अभी जाके देखना पड़ेगा, मैं ब्रदर से कंसल्ट करूंगा कि कैसे क्या है, तो बाद में बताऊंगा मैं बाईपास कैसे करना है। तो वहाँ गया तो ब्रदर बोले कि भाई अपन एक डॉक्टर दास है बॉम्बे में
डॉक्टर दास,
उनसे कंसल्ट कर लेते हैं। तो उनके पास बॉम्बे गया, चेकअप करा। उन्होंने बोला कि भाई अभी कोई आपको जरूरत नहीं है इसके बाईपास का, अभी में ऐसे केसेस।
एंजियोग्राफी रिपोर्ट देख के आपको बोला?
हाँ, बोले एंजियोग्राफी रिपोर्ट देख के बोला कि ऐसे केस मेरे पास बहुत सारे आए हैं, उनमें जो है वो लोग काफी टाइम तक उसको सरवाइव कर गए। तो मुझे बोला कि भाई अब जरूरत नहीं है, आप मेडिसिन ले लीजिए और मेडिसिन पे आप चलने दीजिए।
पवन साहब, सबसे इम्पोर्टेंट है कि आपका कोई सिम्टम नहीं था।
हाँ,
तो एसिम्टोमेटिक, इवन इफ आपका 2 लीजन है LCX में एंड LAD में, फिर भी आपका सिम्टम कुछ नहीं था। और डॉक्टर देवव्रत दास को बॉम्बे में बोला कि नहीं है, और बोले कि सिम्टम नहीं है। इससे बहुत सारी पेशेंट्स और मेडिकल लाइन में ट्रीटमेंट होते हैं। चलिए, बोलिए नेक्स्ट।
उस समय जो है सिम्टम कुछ भी, मुझे तकलीफ तो थी नहीं। मैंने कहा मुझे तकलीफ नहीं है, तो मैं कहा तो वायरस है। इसी चक्कर में फिर जो है ये बोले कि एक टेस्ट होता है परफ्यूजन का, मायोकार्डियल परफ्यूजन स्टडीज होता है, वो टेस्ट करवा के आप देखिए, उसके बाद जो सा होता है अपन देखते हैं। क्योंकि वो टेस्ट करवाया,
फिर आप जसलोक हॉस्पिटल गए और उस टाइम में आप बाइसाइकिल में एक्सरसाइज करके स्ट्रेस और रेस्ट मायोकार्डियल परफ्यूजन स्टडीज किए। हाँ, उस टेस्ट में आई जस्ट वुड लाइक टू शो दिस। This shows there is a perfusion defect in the lateral wall, which is totally reversible in the resting image. So this is a stress image. This is not a pharmacological internal study. Here you can see very well the lateral segment is not here, but it has come back to normal in the resting phase. So that coincides with the occlusion of the NCX after OM1. So shows के reversible ischemia इधर है। और द एंटीरियर में जो LAD आफ्टर D2, बट LAD में शोइंग गुड परफ्यूजन, stress perfusion as well as resting perfusion. So stress perfusion, there is no stress on different, but the only worrying part is the lateral wall, which is reversible at the rest image. And the ejection fraction is very good. So I think 64 or 65, but then at the exercise it was not increasing. That's the only point. It was not increasing at the exercise. And some stress score calculated हुआ है 8 and 3 and some difference score 5. So ये था 2015 का, या 2015 का ये किया है। और 2013 का, या 2013 का जो इमेज, जो उस टाइम में उनको यह प्रॉब्लम नहीं था तो स्ट्रेस किए थे। यहाँ पे भी लैटरल वॉल में भी डिफेक्ट आया है, रिवर्सिबल है, बट एंटीरियर वाज वेरी गुड। एंटीरियर में अच्छा ब्लड सप्लाई है एलईडी में, और यहीं पे वहाँ पे भी लैटरल वॉल का था, इधर भी 8 and 3 था स्कोर, और इंजेक्शन फ्रैक्शन यहाँ पे नॉट इंक्रीजिंग एट द पीक ऑफ द एक्सरसाइज। That is the area, and this is the area, black area is the involved segment of the lateral wall. तो ये दोनों चीज हुआ। देन फिर आपने डेवलप किए सोल्यूशली ऑस्टियोआर्थराइटिस ऑफ द नी जॉइंट। बताइए।
आर्थराइटिस की हुआ प्रॉब्लम, तो मैं सोचा कि इसको ऑपरेट करवाऊं। तो डॉक्टर से एडवाइस लिया, वो बोले कि भाई आप ये हार्ट का टेस्ट करवाइए, तो उसके बाद ही ये पॉसिबल है।
तो इनको पता था क्या ये टेस्ट का देखे थे सब कुछ?
हाँ, ये डॉक्टर साहब
देखे थे। डॉक्टर साहब देखे कि ये डिफेक्ट था, तो ये हार्ट का टेस्ट का करवाया। So with this short history, he came to our department, and we are today doing the IV adenosine with low level exercise of myocardial perfusion studies with the influence of adenosine, and after that the resting adenosine. So here मैं एक बात बोलना चाहता हूँ कि ये इनका ऑस्टियोआर्थराइटिस है, फाइन, इज वन इंडिकेशन। और कौन सा इंडिकेशन में ये स्टडी कर सकते हैं विदाउट डूइंग द ट्रेडमिल स्ट्रेस टेस्ट और द फिजियोलॉजिकल ट्रेडमिल स्ट्रेस टेस्ट? कौन सा कंडीशन से? एक तो हो गया मेरे पेशेंट सामने बैठे तो बायलेटरल ऑस्टियोआर्थराइटिस, और एक पेशेंट से क्रोनिक ऑब्स्ट्रक्टिव एयरवे डिजीज से, सीवियर ब्रोंकियल अस्थमा एंड सीवियर क्रोनिक ऑब्स्ट्रक्टिव डिजीज, पेशेंट कैन नॉट डू एक्सरसाइज इन ट्रेडमिल, सांस फूलता है, ये फूलता है। सो इसलिए उस कंडीशन में हम लोग कर सकते हैं। और कौन सा कंडीशन? फीमेल पेशेंट क्या होता है कि यूजुअली दे आर फैटी होते हैं फीमेल पेशेंट एज कंपेयर टू मेल। इतना फैटी होते तो ट्रेडमिल में चल नहीं पाएंगे। 4 मिनट, 5 मिनट, 4 मिनट ब्रूस प्रोटोकॉल में ग्रेड 1, ग्रेड 2, ग्रेड 3, तो उसमें भी उनको प्रॉब्लम होता है, वो चलने में फीमेल पेशेंट्स का है। और सपोज किसी का कोई पास सर्जरी है, इनका लेग एम्पुटेड है, तो कैसे चलेंगे एक्सरसाइज में? सो दीज आर द एरियाज वेयर हम लोग इसको IV एडिनोसिन और फार्माकोइंटरवेंशन में कर सकते हैं। और आप सोचते होंगे कि इसका सेंसिटिविटी स्पेसिफिसिटी एज कंपेयर टू द नॉर्मल रेगुलर एक्सरसाइज जो करते हैं ट्रेडमिल में और बाइसाइकिल में, आई थिंक सेंसिटिविटी स्पेसिफिसिटी इज एक्सट्रीमली गुड because here what happens when you give adenosine, there is a 6-minute protocol. We give adenosine infusion through a infusion pump, 140 microgram per kg of body per minute. तो 3 मिनट के बाद हम लोग फिर इसको इंजेक्ट करते हैं, हमारा जो ट्रेसर एक्टिविटी, देन और 3 मिनट चला देते हैं। वो क्या करता है? It acts on the A1, A2 receptor of the smooth muscles in our body and it relaxes. सिमिलरली कोरोनरी आर्टरीज में भी स्मूथ मसल्स है, तो उसको रिलैक्स करेगा तो ब्लड सप्लाई जाएगा। बट इफ द कोरोनरी आर्टरी ऑलरेडी स्टेनोस ब्लॉक है, तो वहां पे जा नहीं पाएगा, वहां पे डिफेक्ट दिखाएगा। तो दिस इज द मैकेनिज्म ऑफ एक्शन एंड द हाफ लाइफ ऑफ एडिनोसिन इज वेरी गुड, ओनली 10 seconds. So it is very safe to do with IV adenosine than IV dipyramidal things. And another thing, yes, here suppose the patients have got some हिस्ट्री ऑफ साइड इफेक्ट वेरी मिनिमल, फिर भी ब्रोंको कंस्ट्रिक्शन होता है, थोड़ा पेशेंट को सेंसिटिविटी होते हैं, वो सब चीज में हमारे पास एक उनका एंटीडोट होता है, दैट इज कॉल्ड जाइलोकेम. वी कैन गिव ए IV start dose of जाइलोकेम if suppose there is some side effects which happens. एंड सपोज किसी पेशेंट को इनको ब्रोंकियल अस्थमा का हिस्ट्री नहीं है, सो हम लोग इसको IV एडमिशन कर सकते हैं. सपोज पेशेंट आएगा, वो बोले कि ब्रोंकियल अस्थमा है, तो उसको कैसे फार्माकोकाइनेटिक स्टडी करेंगे? तो उनका एक अल्टरनेटिव मेडिसिन है, दैट इज कॉल्ड IV डबुटामिन स्टडी. सो डबुटामिन का भी हम कैलकुलेट करके उसको देंगे. तो डिफरेंस क्या है कि डबुटामिन एडिनोसिन, dobutamine is a positive inotropic and chronotropic, means it increases the heart rate as well as increases the force of contraction. So in those cases where there is a contraindications for IV adenosine, we can inject them with IV dobutamine, but the accuracy and the physiological things and pathological things almost same. So with this indication, now we will show you how we will do this, his case of IV adenosine with low level exercise. We are a little bit doing on a treadmill, but we are not giving a bruise protocol. Just he will manually walk on the treadmill. That is called the recent trend which I do, IV low level exercise with IV adenosine. So what is the aim of this low level exercise? What is the aim? See, usually when you give adenosine, there is a splanchnic area भी dilatation है, जहाँ पे smooth muscle वहीं पे dilatation होएगा. So there will be a physiologically reduced uptake in the inferior wall physiologically. Suppose the patient is walking on a slowly on a रास्ता में जिससे चलते हैं low level, so that will be splanchnic constriction, so that जो blood supply जाएगा inferior wall को, even if in the influence of IV adenosine. So that is why we are doing it low level exercise with IV adenosine myocardial perfusion studies. With this, now we will take the patient and we will start the procedure. Thank you. We are doing the low level exercise with IV adenosine. Means this is not, we are not following Bruce protocol, stage 1, stage 2, stage 3, because the patient has got severe osteoarthritis. So it will just start on a warm up type, this low level exercise, that is all. And with the IV adenosine, here this is the infusion pump. It will start the IV adenosine at a rate of 140 microgram per kg of body weight per minute for a 6-minute protocol. On the third minute of this, we will inject the technetium labile system by around 11 millicurie, and then again we will continue another 3 minutes to have maximum vasodilation of the smooth muscle. So adenosine works on the principle of alpha 1, alpha 2 receptor activity. It stimulates that. So alpha 1, alpha 2 receptors are there in all smooth muscles in the heart and on the blood vessels. So in the heart, the alpha 1, alpha 2 receptors action on adenosine, that will dilate, so that the more blood will go. So we can have a myocardial perfusion study under the influence of IV adenosine. So now I'll take the blood pressure of the patient, and the heart rate is 106 per minute on the baseline. So I'll give to my technologist the blood pressure. – 140/96 is the resting blood pressure, and the heart rate is 100 per minute. Okay, so we'll start now,
the manual moving of the treadmill belt, as well as we'll start the things. Start the infusion, please. कुछ तकलीफ हो गया तो मेरे को बता. Good. The main aim of combining this low-level exercise with IV adenosine, as you know, adenosine produces vasodilation in everywhere. So the splanchnic blood supply, which is being supplied to the stomach and the intestines, that will also relax. So there will be a pooling of blood into the intestines, so that we may get a false positive on the inferior wall of the heart. If we combine with low-level exercise, there will be a little splanchnic constriction. So more blood will be pumped into the inferior wall. So we may find the false positive of the defect in the inferior wall. That is why I prefer always with the US standard or the European standard, IV adenosine with low-level exercise. Are you comfortable? Good. So look straight and do it aram se. We are not increasing. This is the speed which you have to maintain. We are not doing any bruise protocol, nothing. 130 over 90. Any symptoms like heaviness in the chest, anything, nothing? Okay. Because you know that the side effects of the adenosine infusion, the side effects are very short-lived because the half-life is only 10 seconds. So within 10 seconds the effect goes away. So the side effects are patient may be sensitive to the adenosine, or patient may have bronchoconstriction, so that patient may complain little heaviness in the chest. Or it's not applicable to all patients. So these are the little side. This is best. This is a very good medicine, IV adenosine, as compared to dipyridamole or dobutamine. Now 10 seconds are remaining for injections. So on the third minute of the IV adenosine infusion, we will stop the infusion and start immediately push the injections of IV chestambai, myocardial perfusion, and then again we will restart the infusion for another 3 minutes. So the main aim is behind the after 3 minutes we are starting it, again 3 minutes we are continuing, because it will produce a maximum vasodilatation. That is our aim. 140 over 100. Any problem? Nothing? Very good. Excellent. 140 by 100. Now how many minutes, sister, for the infusion to complete? How many? Only 1 minute. Okay. So now within 1 minute our exercise part of pharmacological intervention will be completed. This is, we are going on the 5th minute, because the whole complete protocol is 6 minutes. On the 3rd minute, we injected technetium labyrinth chestambai, myocardial perfusion imaging agent, and then after that, we are continuing with another 3 minutes to have maximum vasodilatation. So this is the last minute or half a minute, it will be completed. Yeah. बैठ जाइए. हाँ. सिस्टर ब्लड प्रेशर फिक्स करो. (140 over 80). Now you can start giving the sister fatty meal. After giving the technetium labyrinth chestambai, it goes and excreted through the liver only. So in that case, we will have to hasten up the excretion. For that, we will have to give the fatty meal and the chas to increase the excretion from the liver, so that now he will eat the bread butter with the chas. So you can have it. हाँ थोड़ा सा चेंजेस तो हैं पहले भी था इसमें you see that the low level exercise there are changes in B4, B5, B6, ST depression, T inversion, and B1, B2 is okay. B3, B4, B5 that is ST depression, T inversion we are getting in the low level exercise with IV adenosine. The changes are there. IV adenosine with infusion and low level exercise is over. Patient is eating the fatty meal. As soon as patient will complete the fatty meal for the hepatic excretion of the radioisotope, we will take him to our dual head, very latest modality of SPECT gamma camera for imaging of the heart. So with this, we end here. Now we will accompany the patient to the gamma camera room for the imaging part. Now he is ready. We have finished the IV adenosine with low level exercise. Now after that fatty meal to allow hepatic excretion of the radiotracer. Now we are taking him for the imaging. To the gamma camera room, we have a very latest modality of dual head SPECT gamma camera. Dual head SPECT gamma camera Symbia from Siemens, and here we will have to image. And now our technologists are Ananya, Sukla and sisters, they will position and they will start the imaging part. पहले इधर बैठ जाइए आराम से. हाँ. Ananya, you tell everything about the imaging part. Ananya Sukla, she is our RSO radiation safety officer and the technologist, and she will explain you how the imaging will be done. Over to Ananya Sukla.
Cardiac conduction scan. So the detector configuration is 90 degree. The scan will be upward in 78 minutes. Patient is lying feet first supine. Electrodes will be connected to the patient, and then we will begin the scan. There will be 37 frames, 25 seconds each frame duration.
We will have a 180 degree acquisitions to cover all the slices in all the planes. That means short axis, horizontal long axis and vertical long axis. Thus, the stress part is now being undertaken, and after about 3 hours we will do the resting part. Now the patient's positioning is under progress. Are you feeling cold? No, no? Okay. ये रहेगा I think 17 minutes. Only 17 minutes is the acquisition of the images. Then we will have to cut into different slices and we'll generate the slices like you had in just one. Now we are taking the patient inside the detector and to see that whether the positioning is, we are doing the positioning so that it will cover 180 degree acquisition of the heart. So now in the scope, you can see here the myocardium. Here you can see the myocardium. This is the myocardium and this is the liver activity. The excretion is very good with the fatty meal. And this is the myocardium. So they are positioning it. Acquisition has started already. Now here on this computer, we are just acquiring and the process acquisition will start here, and you will see here the image of the heart. Now you can see here from the scope, the acquisition is going on. Here you can see the liver activity, and this is the activity which has gone into the myocardium, and this is the cavity of the myocardium. So this will continue, I think 180 degree acquisition with all the slices in all the planes, and every 10 degree rotate and take the images. And after that we will process and generate the stress image. Stress image means pharmacological stress image with low level exercise. You can see here, this is the myocardium and this is the liver. So this will continue for 17 minutes and acquiring on a 180 degree plane all the images. After the stress part will be over, then there is a gap of 3 hours for the resting image. Resting image, we will inject again the technetium level radioisotope, that is called technetium level sestambai, and we will give again the fatty meal and we will take the resting image acquisition. Then we will compare the stress images along with the rest images and see perfusion defect which will appear either in lateral, previously it was in lateral wall. Let's see what is the things coming out, and then we'll see that it is reversible or non-reversible with the resting image. If it is a ischemia, it will be reversible. If it is a non-ischemia, scarred myocardium because of the past myocardial infarction, it will be non-reversible. So non-reversible means you will get a defect in this stress image as well as the rest image today after 3 hours. With this, I have completed this IV adenosine with low level exercise in our Department of Nuclear Medicine and PET of Aurobindo Institute of Medical Science, and you will be glad to know, and it is my pleasure to inform you all that this is the first time in the state of Madhya Pradesh, in Indore, we have started these new studies. The patients who cannot do exercise on the treadmill, whatever is the causes, osteoarthritis, amputated leg, female patient, fatty patient, those patients who cannot run on the treadmill, this is an alternative. We can do the same information, same sensitivity and specificity with IV adenosine. With this, I end my studies today. Thank you all for your patience. Thank you. We have now completed the stress part of that patient of pharmacological intervention study, and the rest part we just completed this thing. The first row is the stress row and the second row is rest, and this is in short axis slice. This is vertical long axis slice, stress row, and this is the rest row. This is a horizontal long axis slice, stress row and the rest row. So here you can see there is a perfusion defect or the reduced perfusion pattern in the lateral wall, which is much better in the rest image. It is filling it up. Here you can appreciate much better. This is the lateral wall of the heart muscles showing a perfusion defect and which is reversible with the resting image. You can see the intensity of the image of the counts here, stress part and the rest part. But however, anterior part is doing almost okay, and anteroseptal part, and there is nothing to be worried. But here the lateral wall is definitely a perfusion defect at pharmacological stress and which is filling it up at rest. Now we'll go the ejection fractions. Now we'll go to quantitate how much is the heart muscles which has been involved. So this is very unique to nuclear medicine field, unlike MRI or CT. So if you say this is the 100% of the myocardium stress images, this is the rest image and this is a reversible image. So if you can see, this is the 27% of the myocardium out of 100% has been involved, and which has reduced to 18% at the rest with the injection, and these are the ischemic zone which is reversible. But there are other non-ischemic zones which are still persisting in stress and rest. That is why we calculate the summed stress score, sum rest score and sum difference score. Some stress score shows 11, then the rest score is 7. Still 4 difference is there. If it is 100%, then 11, 11, 0. So these 4 segments which is remaining is nothing but the infarcted scar myocardium here. It is there, so which is fibrotic or infarcted. And the ejection fraction, normally the normal ejection fraction at rest 68%. When you gave pharmacological intervention study, it should have increased by 4 to 5 points, but it has fallen. 68% has fallen to 64%. Now let's see the wall motion abnormalities, how it is showing. So if you see the wall motion, now you can see the wall motion of the ventricle. So here you can see the lateral wall is moving very less as compared to the septal, anterior and inferior. There is a hypokinesia seen in the lateral segments of the myocardium. Here you can appreciate much better. Okay, and these are the end diastolic frame and the end systolic frame. So even if you see there is a little deficient in the contraction at the lateral wall, which was from the end diastolic image and the end systolic image. So there is a perfusion defect and there is a affected segments in the lateral wall. Now we will go to the coronary to compare the coronary imaging. So coronary imaging so there are the different areas, LAD, LCX and RCA. So LAD is not very significant, only 8%, not very significant. As compared to LCX, left circle, 91% of the ischemic perfusion defect is there. That has been calculated, perfusion. But in rest, the LCX has come only to 89%. But still, there are lots of areas which has not been perfused. Probably the 47% of the areas of the lateral wall is not getting perfused, and it looks like to be a fixed area, doesn't have any significant viable myocardium. And this is the area of the viable myocardium. This shows that there is a 44% of the myocardium is reversible, viable, but 47% looks to be fixed. So this is quite alarming, and you can see that. And RCA is 100% normal, and LAD 92%, 8% only. It's not very significant. I think the patient is referred to us to find out how much, and if you compare with the images on the earlier 2015 image with the same adenosine 2015, yes. If you can see, can you go into the first phase? If you can see, I am just comparing here, and if you see here, the lateral part is still not there and reversible. Here you can see the lateral part is reversible. It's almost same pattern. The lateral wall, this is a perfusion defect and is reversible with the resting weight. So pattern is same, and the ejection fraction is almost same. Ejection fraction is 64% at stress and 67% at rest. So it is not increasing. So the same is there here. 68% at rest, which was earlier 67%, almost same ejection fraction at rest, and fall at exercise to 64%, and this is also 64% fall. So almost the pattern as compared to 2015 report, the findings are normal, but only thing that we have quantitated the amount of viable myocardium. We are not getting the enough of viable myocardium adequate. Still there are some areas of scarred or infarcted myocardium which you have just seen that. Here you can see here. So here it should have been, if it is totally 100% ischemic myocardium, this is the area of viable myocardium. It should have covered the whole area. So there are other black areas or grey areas which are not having viable myocardium, and which is also getting reflected here 27, then 18 rest. So there is only 9 difference, and the 18 is reversibility. The rest 9% is not reversibility. So there are some non-ischemic area which is also been detected in the present scan. Thank you.